Good morning, good afternoon, good evening. I am Mike Toso, a program officer with Johns Hopkins Center for Communication Programs. On behalf of our Breakthrough Action Project, I'd like to welcome everyone to the fourth in our series of malaria social and behavior change evidence discussions. The discussion guide you received beforehand contains a number of questions that will be addressed throughout this and every evidence discussion. The goals of these evidence discussions are to support malaria social and behavior change practitioners who are interested in learning from emerging research. These discussions are deliberately structured to be accessible to every level of comfort with research methods and terminology. Malaria SBC practitioners should be able to comfortably read, interpret, report on, and apply findings from peer-reviewed literature, and it's our goal to help you with that. We hope that by dissecting malaria SBC publications together, the lessons learned in the discussions that follow will help practitioners envision pragmatic, rigorously designed activities. Now I'd like to introduce Chantel Owens. Chantel is a malaria advisor for the US President's Malaria Initiative. As a member of the social and behavior change team, she provides support to PMI programs in Ghana, Guinea, and Cameroon. Chantel is going to start us off today with a few words about how this activity fits with PMI's global strategy. Welcome, Chantel.
Hi, thank you, Michael. Good day, everyone. Thank you for your participation in the call. The U.S. President's Malaria Initiative is supporting this activity, and I would like to take a moment to highlight how this fits into the PMI global strategy. As you well know, PMI supports and prioritizes activities that improve countries' capacity to collect and operationalize information to increase the uptake of malaria interventions and contribute to the global reduction of malaria-related morbidity and mortality. While the focus is often on country-level data collection, PMI's broader objective is to garner lessons learned from all available data that can then be tailored to a country's specific context and needs. We are also very interested in building capacity and strengthening the health systems of countries where we work. From our perspective, regular discussion about rigorous malaria SBC evidence builds and maintains capacity amongst the malaria community, while underscoring the important and cross-cutting role that SBC plays in achieving individual and community-level impact. We are happy to present this webinar and look forward to hearing from you on how we can continue to support your needs. Again, thank you for your participation today.
If you're going to follow along in the discussion guide, the blue translation slides will indicate which section addresses specific questions in the guide. A word about the structure of these discussions. In each discussion, we will pull an article from the Malaria SBC evidence database. We discuss each article from that database through the lens of the socio-ecological model. A little bit more about that in a minute. Today's article comes from an online searchable database of malaria SBC evidence, which includes both peer-reviewed articles and gray literature. Please take time to explore it when you have a chance. In addition to learning about Dr. Kilian's analysis, we hope today's discussion sheds lights on tips for reading and interpreting malaria SBC research for your own work. To introduce our presenter, Dr. Albert Kilian. Since 1992, Albert has been active in public health and has specialized in M&E with an emphasis on quantitative data collection and operational research. His experience includes 15 years in developing countries' health systems, working at district and national levels, and 5 years as a technical advisor for the Ugandan Ministry of Health. He's carried out malaria and public health consultancies in over 15 countries in Africa and Asia, and has intensive experience with over 40 peer-reviewed publications. Albert has been a key member of the Rollback Malaria M&E Reference Group and is globally recognized for his innovative work in M&E. Albert originally trained as a pediatrician before obtaining a diploma in tropical medicine and medical parasitology and a master's of public health, focusing on epidemiology and statistics. Welcome, Dr. Kilian. Before we dive into our research today, we'd like to frame our discussion around the socio-ecological model, which we find helpful in social and behavior change to think about who and what influences important decision-making. The evidence base we just mentioned describes a growing body of research, findings that tell us behavior isn't simply an exchange of information with an individual. People make decisions based on a number of individual, social, and structural influences. A recurring theme in this evidence discussion series will be a focus on interventions designed to influence multiple audiences and structures within this model. When we say that the social ecological model influences our work, we're acknowledging that working on individual social and structural levels must be addressed to achieve positive behaviors and health outcomes. We've populated this slide with a social ecological model. And next to each level of the model, we've listed a few examples of the factors and interventions at individual, interpersonal, community, and societal levels that were addressed over the course of mosquito net distributions in Nigeria, analyzed in Dr. Kilian's paper. We'll now pass the floor to our presenter for today. Welcome, Dr. Albert Kilian.
Thank you very much, Mike, and welcome everybody. I will now present some of the aspects and results of the study, and we'll follow the discussion guide that you have available. So I will start with the general overview and objectives of the study. This was a secondary data analysis that had the objective to investigate the influence of social and behavior change on insecticide-treated nets use and hanging. And the outcome in this analysis were defined as the effects of SBC message exposure and recall on the knowledge, attitudes, perception, intentions that lead then to actual ITN use. This was done to assist the Nigeria National Malaria Elimination Program to fine-tune its SBC strategy some time back to inform them on future strategies for their mass campaigns. Next slide. So the surveys, the 10 surveys that we're talking about were actually undertaken between 2009, when the first campaign happened in Nigeria, and 2012. You see here the 10 states that were involved. And these were surveys that were undertaken by two projects. One is a so-called SunMap project, support for the National Malaria Control Program funded by the UK8 and DFID. And then the second was the source of PMI's Networks project, the predecessor of the VectorWorks project. All these surveys were planned and implemented by Malaria Consortium, for which I worked at the time. And the objectives of these surveys was not primarily to look into SBC and ITN use, but it was actually to track the results of the ITN mass campaigns, the success in coverage in a time frame between 6 and 12 months after the campaigns. Next slide. So here you see the map where the states that were involved. And you can see there were 5 states in the north, 5 states in the south, and none in the southeast, because one, the projects didn't cover this area, and second, also at the time, 2009, there was already some conflict with Boko Haram in these areas. It's important to know that all these surveys had representative state samples, and we use two-stage cluster sampling design, where the clusters were selected with probability proportion to size, meaning they were exactly representing the structure of population in that state. Within each cluster, the household was selected with simple random sampling from lists that were compiled on the day of the surveys, and we had 1 respondent from the household per each sampled household. In the table, you can see the target for each of the surveys was approximately 1,020 households, and which was largely achieved. We had a total in the 10 surveys of 10,286 households, representing about 50,000 people. Next slide. So let's now talk about the methods, the design of the secondary analysis, and the statistical procedures that we used. Just to remind you, this was not an intervention trial, but rather just the cross-sectional observational or multiple cross-sectional surveys that assessed the status at one moment in time. The interventions also were not controlled by those people who did the survey, but they were those implemented by the states at the time, and in such they varied in time and intensity. But what we did have is we had outcome measures, which were clearly defined as hanging of ITNs in the household in ITN use the previous night and the week before by the households and their respondents. We also had exposure variables to SBC messages And this was, as usually in these surveys, was defined as hearing any message about net and net use in the 6 months preceding the survey. And we had information about what sources this information came from. And in addition, we, in the surveys, in the questionnaires, we captured respondent message recall to specific messages, but also more composite household perceptions and attitudes towards ITN use. Next. The challenge in this kind of approach was that we had to link ITN use with SBC messages, being aware and controlling, therefore, for all the different factors that influence ITN use, such as availability of other nets, seasonal, broad education, etc., as well as being aware that even exposure to the messages is influenced by itself by a lot of different other factors that have to be controlled. And to approach this issue, we use the process in 3 steps. Next. First, we just look at the exposure to SBC messages, the coverage. Did you hear any message? The intensity, how many different information sources did you have? And looked at how different communication channels were characterized by the reach that they had in the target population. Then in the second step, we looked at, if this is the exposure, can we measure the recall? Is recall of messages in a dose response relationship, the more you expose, the more you recall? If that can be established, we have a link between the exposure of messages to something that people took up from these messages. And in the third step, we needed to link this effect then to actual net use. And we used 3 measures, which we would call a composite SBC outcome, which we consider then to be an effect of exposure and recall. And the first one is the confidence to take action to protect your family with nets. Second, the discussing of net use within your family. And thirdly, the expressed intention to use nets every night of the household or the household respondent. Next. The first, or 2 of them, discussing ITN use and intention to use, were direct questions in the questionnaire. However, the confidence to take action was not a single question, but it was actually a composite measure of a series of liquor type questions. Next slide. Here you just see the list of the one that we used for this action variable. And there were 6 statements read to the respondents, to which they could respond to strongly agree, disagree towards strongly agree. And for each of these questions, when we coded the responses to 0 if it was neutral, -2 it was strongly disagree, and +2 that it was strongly in agreement, meaning that then 0 would represent a neutral position, and anything that is positive in value tends towards a positive reaction, and a negative value towards a negative reaction. Next. We would then score for each household the mean from these aggregate scores, and then group them into 4 categories between poor, which was below 0, and on the maximum an excellent response, which would be more than 1.5 for that individual household. The similar assessment was also done for knowledge and perception. Next. So here's just to show you again these 3 steps that we created to try to get the link in this cross-sectional data from SBC exposure to the correlation of recall with action via our 3 composite measures. Next. The statistical approach was that to make this link, we used multivariable modeling to measure the impact. And this was, if you will, one model that modeled the determinants of ITN use. In that, SBC is one variable, but instead of sticking in a single variable, the model uses a second model that accounts for the determinants of being exposed. So therefore, we create within our data set, which is only observational, but we create a counterfactual for each observation, meaning that what would have happened if an exposed household would not have been exposed? And what would have happened if a non-exposed household would be exposed, thereby allowing the evaluation for the treatment effect alone and controlling for the other factors to the extent it is possible. So this statistical procedure that was undertaken in STARTA, in this case, is called inverse probability weight regression adjustment, and is probably available also in other software other than STARTA. Next. So now we want to look at the different three steps and what results we saw and what impact we could actually measure. Next. Overall, there was about 50%, 58% of our households had been exposed to messages in the previous 6 months before the surveys. What we did see is that this exposure was very strongly correlated with net ownership and be actively participating in the mass distribution campaign. On the graphic, you can see in the light blue, this is the proportion of households that had any information source, and in green, those households that could recall 2 or more messages from these exposures. So you can see if the household had no net whatsoever, there was some exposure, but it was small. Households that had a net but did not participate in the campaign, did not receive a net from the campaign, therefore were not exposed to all the BCC around it, had more exposure, more recall, but it still was not very strong. But households that participated in the campaign, were exposed to all the media around there, had a very, very, very strong exposure and also recall. We also saw that with time from the campaign, the longer the period since the campaign, actually the more exposure we could measure. Other factors that were strongly associated with being exposed were larger families with children were more likely to have heard messages, female-headed households, and households that owned a radio, irrespective of which wealth quintile they were in, because wealth itself, as well as urban, rural, education of the head of household, or a difference between North and South were not found, meaning they were even across these variables. Next. So here we now look at the different channels, and we defined out of the different variables that were captured in the questionnaire, a total of 5 main channels. And the values you see here is the proportion of all households sampled that reported exposure to this media channel. And you can see none of them really exceeded much 20% of all households reached. The highest was still media, but mainly radio, to some extent drama. The second were the campaign channels, which was mainly the leaflet, which was distributed over during the campaign phases. The third was what we called health system, which essentially is interpersonal communication through health workers. Then we had the mediators, which were community leaders, politicians, town announcers, and faith-based leaders in the community. And then finally, we had what we call the social network, which is information that came from friends and family, which it still had 15% reach out of all households exposed, sampled. Next slide, please. So here we look at more detail at these channels and look at, we said before, it was the more time elapsed, the more exposure we found. But this was very different from the different channels. And you can see in this graph here, the red line, which is the health worker, the interpersonal communication, has the strongest increase with time, which makes sense because you have exposure to the health worker when you go to the health facility, and that accumulates over time. So the more visits you had made to the health facility, the more you were exposed to the health worker and their communication. There was also, a little bit surprisingly maybe, a positive reaction with the campaign. we assumed that this was because the leaflets were circulating and people started looking at the leaflets, not only at the time of the campaign, but also increasingly afterwards. And then in between that, the green line, where we put community leaders, which also we can see the more time elapsed, the more you were likely to have been exposed to specific messages from the local leaders. Where we did not see in effect with time, or contrary, we saw an early effect, but then a decline was in the media for one. So they only were probably issued around the campaign, but not afterwards. And they didn't have a lasting effect of memory. And also the family communication. We saw it was strong in the first 3 to 6 months after the campaign, but after that it waned quickly. We then ran a separate regression model for each of these channels to see whether the people exposed to it differed, and whether the reach of these channels was the same or complementary. And we indeed saw that it was quite complementary. If you look at campaign health workers and media, most of them were associated, or they were more strongly associated with wealthier people, with better educated people, with people with large households, and with children, people who owned radio. In contrast, local leaders, town announcers, were much, much stronger in the less educated, in older heads of household, were much stronger in the north than they were in the south. And social networks, family and friends, we found to be much stronger in better off households, but also the young families, just a couple with a child. And it was stronger in urban vis-a-vis rural environments. So we can see different channels reach different kinds of populations at multiple times. So now we look at the second step, the link between messages recall and the action mediators. And this is to show you, to remind you our action score, the confidence to take action to prevent malaria in the family, how it was developed. And you see here the average responses to these 6 cost questions, and the different levels of scoring that resulted from it. Next. So if we look at the left graph, you see the adjusted mean action score against the number of information sources mentioned. And we can see the more you were exposed, the more you recalled, the stronger your average score in the household was in confidence of taking action. So a very, very clear relationship of linking SBC exposure to recall to being ready to take action. In the middle, you see the effect of the seasonality, which means in the dry season and in the late rains after, when the mosquitoes are already going down, it was, the average score was much lower. But in the peak rain season, when transmission is highest and mosquitoes are most present, then the action score was also highest. And thirdly, on the right, you can see that there was some trend also, although not quite as strong with education, that the better education the head of household had, the slightly higher was the readiness to take action. Obviously, we also found that owning nets strongly really helped to be ready to take action to use them. In the same way, also, we found that the north was much better than the south, and large families with children better than small families without children. We saw some little effect of time, and we did not see an effect of wealth. So irrespective of whether you're poor or rich, relatively speaking, the effect were the same. Next. Here we look now at the other two, discussion of net use in the household in the yellow lines, and then the intention to use your net every night by the respondent of the household in the survey, which is the blue line. And if you first look at the right-hand graph, you can see there's a very, very strong relationship between the odds ratio, the likelihood of discussing in your family, with the number of messages that were recalled by the respondent. And you can say, if you heard 4 or 5, or you could recall 4 or 5 messages, tenfold increase in the odds of discussing net use in your family. We did not see such relationship with intention to use, but we did on the left-hand side see both variables strongly correlated with our action score. The higher your action score was, the more likely you were to discuss and intend to use net regularly. In the sense that if you had an excellent score in that household, the odds were 4 times higher of discussing and intending to use. So we could here establish the relationship as we had intended. Next. So in the third step now, we look at the use and the impact, but we want to first look at what other aspects we can know about ITN use. And in this graph, you see on the y-axis, the proportion of the population in the sampled households that used an ITN the previous night in percent. On the x-axis, you see the age groups. There are 4 groups presented, 4 lines. In green, those are the households that had enough nets to cover every person in the household, 1 net for every 2 people in that specific household. And in red are households that have some nets, but not enough for everybody. And then you see the solid line are the females and the dashed line are the males. So our first observation is, if there are enough nets in the household, the green lines, we see across all ages and gender a similar level of ITN use, which in this case on average is only 60%, but it varied very significantly from areas, and it was in the dry season in the north was exceeding 80%. Secondly, we see if there are not enough nets, then there is a prioritization. You can see on the red lines, the under 5s are the preferred group, then older children, it declines, it is lowest in the adolescents, and then increases again. But here we see a very distinct difference between males and females, from 15 to 49 in our reproductive health group. Females are significantly preferred over males if there are not enough nets. So this is what we see repeat again and again in many, many data sets, and we can also confirm it here in Nigeria. And we saw, in addition to that, that ITN use was higher in those who did not report difficulties in hanging nets. It was higher during the mid-rains, vis-a-vis the peak of the rains. And it was overall stronger, but also more seasonally variable in the northern parts of Nigeria. Next. So now we have established the determinants, and we have plugged in all these different determinants of exposure and ITN use into our nested model. And you can see here the ultimate effect of our impact. And I want you to look at the right-hand column where it says treatment effect model. Here you see for the first variable, confidence to take action. If you had a poor action score, the average adjusted proportion of people who used the net the last night was 27.4%. It increased to 37, it was good, 43 when it was very good, and 45% if it was excellent. Meaning a 17% point increase between poor and excellent action score in ITN use, controlling for all other factors. In a similar way, we could see the intention to use net every night and not every night. You can see an increase of 15% points from this action on the ITN use, and a slightly less impact on the discussion to use an ITN, or the discussion of ITN use in the household, where we saw only an 8-point increase. Next. So what does this all mean? So we now need to look at the programmatic implications, look at strengths and weaknesses, and how this is generalizable. First of all, we can say, obviously, there was no single communication channel that alone reached more than 1/4 or 1/3 of the households, meaning we need, as we always knew, multi-channel, multimedia, mutual reinforcing communication to achieve the levels of SBC exposure that is needed to change behavior. And secondly, exposure and measures recall increases over time. It is an additive phenomenon. So communication about ITNs or any other thing should not be limited in one point in time, but has to be continuous to reinforce itself and get the effects that we desire. Next. The strength of this analysis on the one hand was that we could pool 10 post-campaign data sets that had been carried out exactly in the same way. And therefore we had a huge sample size of over 10,000 households, which allows us to also look at small impacts which in a single survey would have been lost. And strength was also, or relative strength, that all these surveys were population representative for the states they were taken in. Next. But of course, there were limitations. And one is, of course, we could not measure exposure to BCC directly. We had to rely on people saying, did you hear any messages and where did you have it? Did it come from? Meaning, in the second point, that like all household interview surveys, we were reliant on recall and therefore exposed to the biases of recall, misclassification, social desirability, and other things. So that, of course, is a weakness that we have to take into account. Next. If we look at lessons learned and look at generalizability, we had said these samples were representative for each of the states. However, we cannot necessarily say automatically that this applies in the very same way to the other states. You also have to take into account that the campaigns were done in different times in different places. So other contextual factors may have changed that we didn't capture. And of course, we would say, yes, while we tried the best we could to take an observational data set and make impact, ideally always we have to remind ourselves that if we want to measure impact of specific interventions, we need as a minimum defined control groups and data collected before and after interventions, which was not possible in this case. Next. So in total, we can say and conclude that this multi-channel SBC in Nigeria was effective in contributing to increases in ITN hanging and use, and particularly among the vulnerable groups. And there was the increasing confidence to take action was found in spite of all the differences that we saw between climate, culture, etc. It was one of the driving forces that was needed to change in, behavior towards increases of ITN use. Thank you very much. I think the next slide. This concludes then my presentation, and we will now move to the discussion section. I hand back to Mike.
Thank you so much, Dr. Kilian. So we've got some questions in the chat box. Please, everyone, take a minute or two to enter your own questions or ideas for discussion. We're going to start with a question from Joel, I believe from Uganda. He is asking, were community dialogues included in the study as well, since they were part of interpersonal communication? Dr. Kilian, were community dialogues, was that included in the umbrella under the category of I believe you had mediators and you had community health workers?
Yes, there was no such category as community event or something, although some may have happened, but it was not captured, no.
Okay, thank you. We have another question from Gabrielle. Did all the surveys ask about exposure and net use the night before and the week before in the same way? Was that standardization accomplished across 10 surveys? If those questions were not standardized, how did you manage any differences during data analysis?
No, they were standardized, exactly the same questionnaire. With minor, some questions, some states had additional questions, but the central structure was exactly the same.
And Dr. Kilian, you developed these questionnaires, correct?
Not only me, no. This was done in collaboration. We started out basically with the malaria indicator survey questionnaire, and then this was development between the SBC people under the SunMap project in Nigeria, as well as people from networks, CCP, and people from Malaria Consortium. So it was a joint effort also with the NMEP in Nigeria to fine-tune these questions. We had developed this Likert course question over a longer period of time. And then, although sometimes we had other points say, okay, maybe we should change them, but we did not, in order to just, as we said before, to have exactly the same structure and the same possibilities across all these surveys.
Okay. And how long before these distributions were the surveys developed, and how long afterwards were you able to see the results disseminated and ultimately used by the program?
I'm not sure I understood that. Can you repeat that?
I was going to say, how long before the distributions were the surveys developed, and how long after the surveys were conducted was the program able to start using and disseminating the data?
No, the surveys were actually developed in order to measure the impact of the campaigns. And it started with the first campaigns, which was in Kanu in 2009. So the surveys were done somewhere between 4 and I think the longest was 13 months after the campaign.
Thank you. We have another question here from Greg. Does the active participation in the campaign lead to an increase in knowledge, self-efficacy, and behavior? In other words, does participation become a transformational factor?
Well, we looked at knowledge and also could see that knowledge also increased, but there was not a very strong link between the knowledge and the actual behavior. The action score was a much better predictor of actual behavior than knowledge.
Thank you. We have another question from Zila in Niger. She's asking, what was the overall coverage of the ITN campaign, and did that have any effect?
What the proportion of the households that actually were reached by the campaign, that varied very dramatically. We had the best ones were in the range of population access of 80%. And then there were some states that had difficulties in their implementation and that had only about 60 population access as a result of the campaign. So it was, you could say, a range between 50–60% population access immediately after after the campaign, up to 80–85%.
And these were campaigns that were rolling out state by state over multiple years, correct?
Yes, that's correct.
Do you have a feeling that if in countries where ITN campaigns are happening all throughout the country at the same time, do you think that there's a way to measure whether or not the impact that all of those channels happening simultaneously across the country, whether or not the impact should be greater as opposed to state by state?
Well, that might be possible, but I'm not entirely sure why it should be, because people don't listen to what other people in the next state are listening to necessarily. I mean, I'm not an SBC expert, so I probably leave that maybe this discussion point to others. But my intuitive reaction would be whether you do it subsequently or not. I mean, there may be a culture building up. We did see in the Nigeria data that surveys that were done in 2012 had sort of a different effect. Or slightly better effect than the first ones in 2009 and 2010. Whether that was a learning effect or not, I can't say, because it could just be by chance. It's difficult to say.
Sure. Thank you. We've got another question here from Minchin. Has there been any efforts in the regions in your study or in these surveys to integrate SBC into aspects of training for healthcare workers and health professionals? Does it affect the dose if an individual or household interacts with a healthcare worker that has SBC for ITN uptake background?
That I don't know, because we couldn't measure that, because we didn't know whether, we just heard, we recorded that the person got information from the health worker, but whether that health worker were exposed to other training or not, that information we don't have. So this would be certainly an interesting question, but it's not one that we could answer by this cross-sectional survey. If you look at, sorry, our data from Vectorworks, our durability monitoring studies, where we also looked at a little bit at BCC or SBC exposures and effects, we did see there that actually interpersonal communication in some respects seemed to work better than media exposure. But whether that is whether you train the health worker or or not, it's difficult. I don't have information about that, so it's certainly an interesting topic for operations research.
Sure. We've got another question here from Miko in Cote d'Ivoire. She's asking, were you able to look at any service statistics to see any impact on incidents?
No, these surveys did not measure parasite rates or clinical incidents.
Thank you. We've got another question from Bola. She's saying, right now there is so much data collected from numerous projects, implementing partners, funders. Secondary analysis of these data would be more efficient. From your experience, how are you able to access the study data across projects and funders?
Well, I have no experience in trying to access data that I didn't collect myself. So in this case, I mean, the good things was these, and actually we did some other analysis across multiple countries, but again, these were all surveys that the project I was involved in at the time were the ones who actually collected the data. How difficult it is to get access to data from other projects, I can't really say. It depends also, I mean, it certainly would be a huge source. The problem there is always, like with DHS surveys, how standardized are the questionnaires? And sometimes you may run into trouble aligning these. But theoretically, I think it would be worthwhile to, in the absence of intervention control trials on SBC, which are challenging by themselves, doing more secondary analysis to highlight the relationship between SBC exposure and outcomes would be desirable. But how easy it is to get data sets from other projects where you were not involved in, I don't know. I have no experience with that.
Sure. We've got another question. Do you know whether or not the language that the messages were disseminated in, whether Pidgin, English, local languages? Yeah. Do you know, was there any data collected on which languages these were being disseminated in?
No, there was not, but I assume that in the different regions, the most messages in the health facilities, for example, there were delivered in local languages, as well as were leaflets and radio messages. But we didn't have, as I said before, we only had the questionnaires from the surveys. We did not have detailed information on which languages the radio messages were in, but I'm pretty certain they were in local languages.
Sure. We've got a question here from Maudie. Do you have any thoughts about findings of other channels like short message, SMS, or any other kinds of social media?
I have no data on that, and we didn't check that, so I can't really speak to that.
Okay. We've got a question from Coco. What is the coverage rate penetration of ITN in rural communities in Nigeria? And what is the percentage of ITN usage by those who had the opportunity to collect them?
The first part was about urban. Is that correct?
What is the coverage rate and penetration of ITN in rural communities in Nigeria?
In rural, well, it depends. But you have to be aware, particularly also with our campaign strategies of doing repeat campaigns every 3 or so years. There is no fixed coverage at any point because it's always variable. It goes up and down. If you distribute, it's high, then it starts sliding down, then you distribute again. So the outcome always depends on how long the nets last, how often they're distributed, how well people have access in between campaigns to additional nets through either the private sector or routine distribution through health facilities. So, there is no one answer to that, but what we can say, and that is true across so many countries and places, that wherever you look, once people have a net, they use it. So use that we observe sometimes to go down is because the nets go down, not so much the intention to use.
So not related to this, the analysis of these surveys, but you've done quite a bit of work designing and analyzing data about net durability. We've got a question here from Zila in Niger. She's wondering if net durability is or could be linked to the uptake of specific messages.
I didn't look into that, I can't say.
I'm wondering, just thinking off the top of my head, do we have any data that says messages about net care or net repair, have they ever been linked, for example, to the longer lifespan of an ITN?
Well, yes, that one I can't answer because I'm just working on a publication on that right now. We looked at the actual the ability, the recall of messages of net repair, but also how it translates into action and how the actual repairs translate into impact on durability. And the long and the short of it is, it ain't there. People do respond to net use, yes, but they do not respond to repairs. Repairs pick up very slowly. They only start repairing that when the net is already too torn, so it has absolutely no impact on the longevity of the net.
Thank you, that's useful. We have another question from Sonali. She's wondering what proportion of people surveyed owned radios in these states.
I don't have that at the top of my head. It of course varies from place to place. If you go to areas where you have, the urban areas where you have electricity, people tend to have more other means of communication rather than radio. They seem to have them more in rural areas. If I recall correctly, it varies somewhere between 40 and 60%. But I would have to check that. I don't have it at the top of my head, sorry.
Sure, and I'm sure that's a changing statistic as well. A question from Anna McCartney-Melstead over in Cote d'Ivoire. She's asking, do you have any comments on the use access ratio in Nigeria based on the 2018 DHS? So right now the DHS, it's 91%. Maybe you could just briefly describe what we mean by the use access ratio and then maybe comment on that question.
Okay, I don't have the 2018 DHS data in my head right now, but in general, what we always do in this kind of analysis is we first look at population access to an ITN, that is the potential, the proportion of people that potentially could use an ITN, and compare that then to the actual use, which then we can present as use if access, or the access use ratio, meaning that what I said before, that if people have the opportunity to use a net, then do they also use it? And we normally find that these are very, very, or much, much higher than if you only look at the proportion of population that uses a net last night would suggest, because many of the people don't have a net to use. Therefore, but what we can say, I'm more familiar with the 2015 data from Nigeria, but also actually no, to some extent the 2018 also. I mean, what we always see is very clearly, one, in the north, in the rainy season, access to use ratio is extremely high. Almost everybody who has a net uses it. However, in the dry season in the north, it can get down very, very low to only 40% of those who have access that are actually using. In contrast, in the southern part, where the seasonality is not so pronounced, we see little change over the year with the seasonality, but we see generally a much lower access to use ratio, which is more in the range of 60, 65%. Than in the north, meaning there is sort of much discipline in the north in the rainy season to use the net, reluctance to do so when there is absolutely dry and no mosquitoes around. But in the southern part, it seems to be a little bit more laissez-faire and everybody for themselves, and therefore the translation of messages to action is a little bit more difficult or delayed in the southern part with a lower use to access ratio. But at least use access ratio or use if access is the most important measure if we want to associate anything between SBC and ITN use. We need to look at these things, not at the pure use alone, unless we control, as we did in our study, for the presence of other nets.
Thank you. And just a message to those looking in the chat box. We've got a link to the use access reports. If you click on that link, you'll find there's actually quite robust data to support not just this trend in Nigeria, but across the Sahel. It appears that the weather patterns and rainfall do have quite an effect. And that the use rates in the rainy season versus the dry season, they tend to vary in countries across the Sahel that have more seasonal rainfall. And those are quite different than in countries where the rainfall is a little bit more consistent. So finally, maybe we've got one last question. This is from Gabrielle. She says, SBC practitioners so often have only cross-sectional data at their disposal. What type of data do you need in order to do this kind of nested treatment effect model that allowed you to create somewhat of a counterfactual? What tips and recommendations would you share with other SBC researchers who have cross-sectional data in order to perform a similarly controlled analysis?
Well, the minimum you need in cross-sectional data is some kind of exposure and ideally a measure of the quantity of exposure. That is the minimum you need. You can then do, for example, a propensity score matching, which is similar to what we did in this study, only a little bit simpler in the sense that you measure the probability of being exposed. And for that, you only need a single exposure measure, and then match respondents to whether they had the same probability of being exposed. And therefore, you can have basically a case control study within your observational data set. That's the minimum, but it would always be ideal to have a little bit more, to include recall of messages and some kind of measure. It doesn't have to be the same that we use, but some kind of measure that can combine all the exposures into some action related variable that is more a composite measure of all the different SBC exposures and effects, ideally. But the minimum you need is simply like in an MIS or DHS data set, if you have exposure and the quantity of exposure, number of sources, number of messages we call, then you can do this kind of analysis.
Thank you so much. Maybe we'll just take this one last question from Sonali. She says, if such a survey was done again, what changes would you suggest to make in the way that you measure exposure to the intervention?
I think in the medium term, I think it would be worthwhile to fine tune this liquor course question, because I think you can have even stronger relationship or correlation between SBC exposure and then the final outcome if we knew a little bit better of to what to look for in these intermediate variables, such as the perception or intention to treat, and developing a more robust set of liquor course questions that we can use for the action score. I think that would be the one thing I would work on.
Thank you so much. I'd like to thank both of our presenters today, Dr. Albert Kilian as well as Chantal Owens. If we can go to the next slide real quick. Before we wrap up the webinar, I want to remind everyone about the resources we mentioned earlier. The Malaria SBC evidence database contains links to infographics. As you can see, we have graphics that show the impact of ITN, service provider, and malaria case management SBC interventions that have been made. We also have a number of fact sheets. These fact sheets synthesize the findings from over 3,600 peer review articles, as well as 1,700 great literature reports. The fact sheets are presented in 3 malaria technical areas: insecticide treated nets, case management, and service providers. Last slide. Finally, thank you so much, Dr. Kilian, for taking the time to speak with us and for sharing your experiences. If anyone has any follow-up questions for Dr. Kilian or about the evidence database, you can find our contacts on this last slide. Finally, if you wouldn't mind sticking around and replying to 3 or 4 questions in a post-webinar survey, we'd appreciate it. Thanks, everyone.
Thank you. Bye-bye.